Preventing on obstructive sleep apnea. And this is the outline I'm following: definition, epidemiology, pathophysiology, types, risk factors, symptoms, diagnosis, and treatment. Definition: obstructive sleep apnea is a condition in which breathing stops involuntarily for brief periods of time during sleep. The normal flow of air is repeatedly stopped throughout the night.
Sorry,
Epidemiology.
can you speak a little bit to your mic?
Okay. Epidemiology. The prevalence of obstructive sleep apnea with associated excessive daytime to 7% in adult men and 2 to 5% in adult women. Result in negative pressure with dilating muscles, including the
I don't know, maybe it's me or I can't hear anything.
incomplete obstruction
Sorry, Dr. Nneka, please could you go back to
causes
slide number 2?
turbulent flow, resulting in snoring, and more severe obstruction triggers in. Okay, no. Okay, this is the second slide.
Well, sorry, it's just that we stopped hearing you at some point, and then when you came back, you had gone like
Hello.
4 slides ahead. Look at the news.
Hello, Chief. Okay, sorry about that. Sorry about that. Condition in which breathing stops involuntarily for brief periods of time during sleep. The normal flow of air is repeatedly stopped throughout the night. Epidemiology. The prevalence of obstructive with excessive daytime slowness is 3 to 7% in adult men and 2 to 5% in adult women. Pathophysiology. Inspiration results in negative muscles, including the palatal to preserve airway patency. During to maintain pharyngeal patency. In some patients, a combination of palatopharynx and on the activity of the dilating respiratory airway obstruction. In more severe obstruction triggers patients, allowing dilating muscle patients have no recollection of them. After a series of loud deep rapidly returns to sleep, snores and becomes apneic once more. Types of central sleep apnea. These occur muscle to breathe. Then the mixed sleep apnea is a combination of the obstructive sleep apnea and the etiology. We have elongation, posturofacial compression, retrogantia and microgantia, mandibular hypoplasia, brachycephalic head form, inferior displacement of the hyoid, adenotonsillar hypertrophy, particularly in children and young adults, particularly in women. They have nasal obstruction, which can be caused
Ah, like your network is very poor.
which can be nocturnal symptoms, which include or turning during. Hello, hello.
Yes, we can hear you, but it's breaking.
We have the daytime symptoms, which includes non-restorative sleep, morning headache, dry or sore throat, excessive daytime sleepiness that usually begins during quiet activities like reading, watching television. As the severity worsens, patients begin to require alertness, daytime fatigue and tiredness, cognitive deficits, which includes memory and intellectual impairments. And we also have decreased vigilance, morning confusion, personality and mood changes, including depression and anxiety, sexual dysfunction, including impotence and decreased libido, gastro. Excessive daytime to help determine situations. And physical Hello? Chief, please, can you people hear me?
You were temporarily off and then you
Sorry,
came
my
back.
network is acting up. Sorry about that.
It's okay.
Most patients have systemic arterial hypertension, which is approximately seen in 50% of patients, congestive heart failure, pulmonary hypertension, stroke, type 2 DM, and metabolic syndrome. Cardiovascular disease in obstructive sleep apnea includes vagal stimulation can cause bradycardia. Bradycardia and hypoxia provoke serious cardiac rhythm disturbance, which can include cardiac arrest, ventricular tachycardia, and premature beat asystole. Diagnostic criteria for obstructive sleep apnea. Individuals must fulfill criterion A or B plus criterion C to be diagnosed with obstructive sleep apnea syndrome. Criteria A includes excessive daytime sleepiness that is not explained by other factors. Criteria B includes two or more of the following that are not explained by other factors, which includes choking or gasping during sleep, recurrent awakenings from sleep, unrefreshing sleep, daytime fatigue, impaired concentration. Criteria C involves overnight monitoring, demonstrates 5 to 10 or more obstructed breathing events per hour during sleep or greater than 30 events per 6 hours of sleep. These events may include any combination of obstructive apnea, hypoapnea, or respiratory effort related arousals. Epworth Sleepiness Scale questionnaire is used to diagnose obstructive sleep apnea and is used to know patients that are responding to treatment. In contrast to just feeling tired, how likely are you? The questionnaire involves asking patients how likely they are to fall asleep in certain situations. A score of 0 is given to when patients will never doze off. Score of 1 is given to slight chance of dozing. A score of 2 is given to moderate chance of dozing, and a score of 3 is given to high chance of dozing. This involves asking the patient how likely they are to fall asleep when sitting or reading, watching TV, sitting inactive in a public place, as a passenger in a car for an hour without break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol, and in a car while stopping for a few minutes in traffic. A score of 12 is associated with a greater propensity to fall asleep on the multiple sleep latency test. It's used to evaluate response to treatment, and as patients are responding to treatment, the score should reduce. Indices for sleep disordered breathing. We have the apnea hypoapnea index, which is defined as average number of episodes of apnea and hypoapnea per hour. We have the respiratory disturbance index, which is defined as average number of respiratory disturbance per hour. And workup includes an overnight sleep study or polysomnography, in-laboratory measurement of sleep architecture and electroencephalographic arousals, eye movement, chin movements, airflow, respiratory efforts, oximetry, electrocardiographic tracings, body position, snoring, and leg movement. Routine laboratory tests usually are not helpful in obstructive sleep apnea unless a specific indication is present. Routine radiographic imaging of the upper airway is usually not performed. American Academy of Sleep Medicine guidelines for performance of polysomnography. It includes sleep stages are recorded via an EEG or electrooculagram and chin electromyogram. Heart rhythm is monitored with a single lead ECG, and leg movements are recorded via an anterior tibialis EMG. And breathing is also monitored, which includes through at the nose and mouth, using both a thermal sensor and a nasal pressure transducer effort, which includes using inductors plethysmography, and oxygen saturation. And the breathing pattern is also analyzed for the presence of apnea and hypoapnea. This is just like a diagram showing obstructive sleep apnea with cessation of airflow of at least 10 seconds with persistent respiratory effort. And this is also another picture showing central apnea with cessation of airflow for at least 10 seconds with no respiratory effort. And this is another diagram showing mixed apnea that begins as a central apnea but ends as an obstructive apnea. The apnea-hypoapnea index is derived from the total number of apneas and hypoapneas divided by the total sleep time. Most sleep centers use a cutoff of 5 to 10 episodes per hour as normal, 5 to 15 episodes per hour for mild, and 15 to 30 episodes per hour for moderate. More than 30 episodes per hour for severe. And the split night polysomnography is used when patients with respiratory disturbance index higher than 40 during the first 2 hours of diagnostic polysomnography. The final portion of the study is used for titrating the continuous positive airway pressure device. And home testing involves 3 levels of portable monitors, which includes level 2, level 3, and level 4. Level 2 involves a portable monitor with the same parameters as a full attended polysomnography. Level 3 involves at least 4 channels, which includes flow, effort, oximetry, and high rate. And level 4 with fewer than 4 channels, often oximetry with flow or oximetry alone. The level 3 monitors are best used to confirm the diagnosis of obstructive sleep apnea. Multiple sleep latency test is an objective measurement of excessive daytime sleepiness. It consists of 4 to 5 naps of 20 minutes duration every 2 hours during the day. The latency of sleep onset for each nap is averaged to determine the daytime sleep latency. Treatment. Mild apnea has a wider variety of options, while moderate to severe apnea should be treated with nasal continuous positive airway pressure (CPAP). Conservative non-surgical treatment involves weight loss. At least 10% reduction in weight leads to 26% reduction in respiratory disturbance index. Avoidance of alcohol for 4 to 6 hours prior to bedtime, and sleeping on one side rather than on the stomach or back. Nasal CPAP therapy is the most effective treatment for obstructive sleep apnea. It increases the caliber of the airway in the retropalatal and retroglossal regions. It increases the lateral dimension of the upper airway and thins the lateral pharyngeal walls, and it maintains the upper airway patency during sleep, preventing the soft tissues from collapsing. This is just a picture showing the nasal insert, full face masks, and the nasal masks. Guidelines for the use of CPAP. All patients with an apnea-hypoapnea index greater than 5 regardless of symptoms needs to be on CPAP. And for patients with an apnea-hypoapnea index of 5 to 14.9, CPAP is indicated if the patient has one of the following: excessive daytime sleepiness, hypertension, or cardiovascular disease. Complication and adverse of sleep. It causes sedation or suffocation or claustrophobia, difficulty in exhaling, inability to sleep, musculoskeletal chest discomfort, aerographia, sinus discomfort, pneumothorax or pneumomediastinum, pneumoencephalus, tympanic membrane rupture, mouth-related problems which include skin abrasion, rash and conjunctivitis, nasal problems which include rhinorrhea, nasal congestion, epistaxis, and nasal or oral dryness. Surgery for obstructive sleep apnea includes nasal surgery, which is septoplasty, sinus surgery, tonsillectomy or adenoectomy, uvulopalatopharyngoplasty, laser-assisted uvulopalatoplasty, radiofrequency volumetric tissue reduction, linguoplasty, genoglossus and hyoid advancement, maxillomandibular advancement, osteotomy, and tracheostomy. Pharmacological therapy include bod- modafinil, which is approved by the US Food and Drug Administration for use in patients who have residual daytime sleepiness despite optimal use of CPAP. Selective serotonin reuptake inhibitors agents such as prazosin, fluoxetine have shown to increase genuglossal muscle activity and decrease REM sleep. Apnea is among common in REM sleep stage of sleep. Although this has not translated to a reduction in apnea-hypopnea index in apnea patients. This is my reference. That's the end of the presentation.
All right. Thank you very much, Nneka, for the presentation. Good evening once again, everyone. Although it didn't move smoothly because of the network issues she was having. So I don't know if there are contributions or questions from medical officers, junior residents. Can you hear me?
Yes, you.
So any questions or contributions?
Sorry, good evening.
Okay,
This
Dr.
is well,
Thomas.
good evening.